I'm presenting my novel Armboard technique for supracondylar fractures, which I picked up from here in Pune with Dr. Sandeep Patwardhan, and I applied it in Singapore. So it's a multi-center study of the two centers. So supracondylar fractures are the most common fractures around the elbow in children that we see. Many techniques have already been described in the literature. So what are the requisites of a good technique? For a good technique should give you a good reduction. You should be able to get a true lateral C-arm image so as to assess the reduction. You should have an ease of wire fixation post-reduction, and the stability should be maintained post-reduction without losing it, and maintaining reduction post-fixation. The techniques that are already described in the literature are the conventional method by placing the elbow on the hand table itself, elbow on the C-arm tube, which is also described in the literature, a lateral position in prone, and giving a counter traction by assistant. So placing the elbow on the table, what hindrances we cause are that table itself interferes with manipulation. You need to place a folded sheet or something under the arm, which can possibly lose the reduction. And also there is difficulty in passing the pin as the instrument will hit the edge of the table itself. Placing the elbow on the C-arm tube will cause damage to the equipment. There is a rare case of electrocution which is described in the literature by Wasim et al. And it's a terrifying thing. There is no support for the limb, and arm is freely mobile so that the fixation, the bone will move when you're trying to fix the fracture. So we describe a simplified technique of intraoperative stabilization and fixation of the supracondylar fractures. And then we compare the results of the clinical outcome of our simplified technique. So two centers, as I mentioned already, India and Singapore. We included 80 children from age group of 2 years to 13 years. The patient on anesthesia, general anesthesia in supine position. The arm is strapped on the armboard. The C-arm is positioned in such a way that the C-arm tube is parallel to the bed on the same side of the arm, and the monitor is on the other side, so there is no hindrance, there is no movement, you can directly see the monitor. So this is the setup of the operating room. So while positioning and reduction, we place the arm board, there's a wooden radiolucent board, under the torso of the patient so that the torso itself stabilizes the arm board. The proximal fragment, the arm is strapped onto the arm board with a cotton sticky bandage, and you don't need to apply severe pressure, just loosely tie it so that there is no movement. It is tied in such a way that the elbow and the distal fragment is kept free. The elbow is allowed to give you reduction, adjust the varus, valgus, adjust flexion or extension depending on the type of the fracture. So you'll see pictures from different setups. So the patients of India and Singapore both you'll see. So this is the one which is positioning before draping in Singapore. So while checking the lateral view, we rotate the C-arm and not rotate the arm so as we don't lose the reduction after we have achieved it. So the ease of movement of C-arm in both AP and lateral views. Then as the distal arm is, the fragment is kept free, it is easy for us to pass the pin without any hindrance. So you can pass it from posterior to anterior depending if it's an oblique fracture line, you want to pass it from anterior to posterior, that is also possible. So ease of placement of pins. What we accept as our reduction criteria is we don't accept any varus or valgus tilt. Both the pillars in the oblique views should be restored, that the medial and lateral supracondylar pillars should be restored. The anterior humeral line should bisect the middle of the capitulum, and no rotation is accepted. So with our simplified technique, we were able to achieve good reduction. We were able to get true lateral image without having a possibility of loss of reduction on table. There is no need for assistance for counter traction as the armboard and the bandage itself will do it. And there is ease for wire fixation without the movement of the arm. So the configurations that we commonly use are parallel divergent pins in 90% of our cases. Of this, one is a pillar pin, one is a pin through the capitulum. And we try to achieve one pin, which is a 4-cortex pin, so as to achieve enough stability. The medial pin we have used in about 10% of cases. These are the cases where the medial condyle is a larger fragment. It's a medial oblique pattern of fracture, or there is extensive medial combination where there is a chance of going to cubitus varus. So the clinical cases, the pre-op and the intra-op pictures. and a 3-month follow-up with clinical range of motion. So all of our types of extension type of fractures were included. Both type 2, type 3 Gartland, the commonest type for fixation, and the fracture lines were oblique and transverse. In about 25% were oblique and 75% cases were transverse fracture line. So our average time to radiological union was 3.5 weeks. The range of motion was nearly complete at the end of 6 months follow-up. So in our study, we were able to achieve good to excellent results in about 90% of cases. This we compared with the already described conventional method in the literature, and those also have a 85 to 90% of good to excellent results. So it's comparative. So in conclusion, our technique is a low demand, locally fabricated radiolucent armboard, which is length adjustable and that can be adjusted to any standard operating table. The technique is safe, effective, and can be easily replicated by any orthopedic surgeon. Thank you.